ladies and gentlemen. I'm sure you must be hungry at this point. I hope you are hungry for some knowledge, because this is definitely what we're going to do in the next 45 minutes to 1 hour. My sister actually said you need to get Shireen Ban for this session because you have such impressive panelists. And I thought of Madhuri Dixit, but if we called her, she said, you know, the people on the panel have a better screen presence than I do. They've actually touched people's heart, quite figuratively. So she declined, and you have me today. The American economist Sung Mai Chang had formulated the universal laws of healthcare systems in a somewhat jocular manner. And he said, no matter how good healthcare is in a particular country, people will always complain about it. No matter how much money we spent, and you heard about that in the last session, the doctors and hospitals will argue that it's never enough, and my father will agree. The last reform has always failed. The best healthcare systems in the world, according to the WHO, are in fact in France and Italy. Structurally, all countries have challenges in meeting the interests of all stakeholders satisfactory and at all times. Yet, as we know, satisfaction is a moving target. The United States spends $2.8 trillion on healthcare, and the jury is still out on the impact of this spending. What is the future of healthcare, and who gets to make the decision on whom it will impact and who it will benefit, and who does it create value for? How will it change the future, and how will it save not only India's population, but provide a model for the fast-changing world that we live in today? With me, quite figuratively, are the rock stars of healthcare. Dr. Devi Shetty, Narayan Hridayalaya Health, Narayana Health is truly going places, from low-cost healthcare in a heart factory in Mysore to high-end, high visibility in the Cayman Islands. I have to admit that I've met him only once, but I've watched him 5 times on teleconference. So we are truly privileged to have you here with us today, Dr. Devi Shetty. Dr. Naresh Trehan, who came back from the US, much like my father, to create a healthcare institution called Medanta. Dr. Trehan has touched many hearts, and the city of Delhi can tell you why. Dr. Trehan revolutionized healthcare, and he did so in the way that he engaged with the different stakeholders to create Medanta. Welcome, Dr. Trehan. Dr. Nata Menamde is a representative of WHO in India. Her experience in dealing with healthcare extends from primary to tertiary care across the world. She has 28 years of experience in working with public health systems and was awarded the gold medal by the President of Georgia. Thank you for being with us today, Dr. Nata Menamde. Shivender Mohan Singh, Executive Vice Chairman, Fortis Healthcare. Shivender is the new kid on the block, but his vision is no less ambitious. Together with his brother, Shivender has built a professional healthcare enterprise with his brave acquisitions. Singh is king in healthcare. Am I right, Shivender? To add depth to our panel, we could not have had someone with greater knowledge and practical experience of managing a $2 billion healthcare enterprise, which is Stanford University. Dr. Ami Rubin, welcome to the future of healthcare. We look forward to hearing your views as an expert on healthcare strategy, lean operations, and customer service, all areas that are relevant for the future of healthcare. In medicine, every second counts, so without wasting this golden hour, let me request Dr. Nata Menamde to speak on her vision of the perfect future.
Good morning, ladies and gentlemen, and thank you for organizers to give me this opportunity to share with you some of my thoughts. And many of you here are representing actually the private health care sector. And I want to start by giving you just my immediate clarification. We in WHO do not talk about universal health care, because universal health care is about provision of service, while we talk about universal health coverage, and that is about coverage to be provided to all the people. So there is a big difference in terms of accent and the center of this discussion. Therefore, what I want to say about my vision, which I was asked to share with the audience, is that I want to see India where mothers and children don't die from the routine, very basic conditions, where in other countries those very mothers and children survive. I want to see that diabetes is not growing in India, but even if it's growing, that those who get diabetes don't get amputation of their legs, but get adequate treatment as they need. And I want this to be available and accessible to all people, and that those people don't have to face catastrophic hardship to avail those services they need. Because many times in India you have those services, but people can't use them. So the challenge is not as much maybe how to generate those services, but how does one make them available. And I don't necessarily agree that it should be government who provides that. I think who provides, it's immaterial. It can be government provider, it can be private sector provider, but what is important that any provider is able to deliver those services to people who need, and that people don't have to immediately pay out of pocket for those services. And it is possible, it has been possible on some small scale, even in India, in some of the schemes that we know, RSBY being one of them, but there are many other schemes which are covering tertiary services in state level. So this is possible. The problem is not so much those schemes, but the disintegration of those schemes. Those schemes don't talk to each other. They are covering different or same population groups. There is a lot of duplication, but there is also a lot of gap. So in my vision, I don't want to talk about determinants of health, because obviously economic growth and improvement of lifestyle and improvement access to other things, education and employment, is improving health outcomes to people. But very importantly, it's also health services. And not only personal health services, but also the population-based services. I want to see every child vaccinated from the preventable diseases in India, no matter whether it's a poor child or not poor child. I want to see this to be exercised as a human rights issue. But I don't want to lecture you about the values of WHO, because many of you know them anyway. I think we need to deal with reality here. And in reality, I think India has to take a very tough call, and universal health coverage concept is the most effective, immediate, available tool which can improve health of people in this country at large in a very fast time frame. What needs to be done is that one has mapping of the real needs of all people in this country, and then mapping of what are the current coverage arrangements for those people, and then to see how do you interlink those different schemes which are vertically providing and reaching out to those people. The seamless flow of the patient between the schemes is a must. I want to see that in India, where child goes to receive care, is the same place where mother goes and the same place where father goes. In the current setup, we have very different situations. For child, you have to go to government-provided scheme. For the employed father, you have to go somewhere else. For mother, you have to go to the pregnant mother. So this is inefficient. It's a waste of resources of this country, even though if those schemes are effective in their own way. So what is required is, and I agree here with the previous panel speakers, that the only only player in this whole range of stakeholders is actually the government, who provides the necessary stewardship, but not to the publicly funded and publicly run health system players, but to the all players, because that's what WHO is saying. WHO says that any country can have one and only one health system. And that health system covers and includes all the players, public and private, population and personal care service providers. And this is necessary for government to see that the quality standards should apply all over to private and the public. And the provision is not an issue. The issue is how do we arrange that the financial coverage, which consists of the pooled resources, is reachable and accessible to all the people that need it. So my vision for India is this. And believe me, world has changed tremendously over the last 100 years. In fact, the life expectancy 100 years back, century back, was only 48 years. Now we have it 67 for women, for men, and 73.5 for women. So it has increased. In India, the life expectancy over last 30 years has increased by a decade. So there are changes, there are significant improvements. Every effort delivers some output, but they can be delivered in a more efficient manner. There is a need to indeed overlook and revisit the regulations. There is absolute essential need to look how the human resource capacity is managed in this country for health service delivery. But first, you have to know what are those services, who require them, what are the volumes, what are the quality standards, and then see who can provide them, and revise all the rules and regulations as necessary to take advantage of India's a lot of opportunities in rural setting, in urban setting, everywhere. But pull yourselves together and look at universal health coverage by all the players rather than universal health care provided by the government to only a segmented part of population and of the questionable quality. Thank you.
Good afternoon. We have one of the highest maternal mortality rate, infant mortality rate in the world. It's blamed as we spend 1% of the GDP on healthcare. That's the reason why we have very high maternal mortality. I can tell you, even if we spend 20% of the GDP on healthcare, our maternal mortality rate can never come down simply because we have created a regulatory structure where only a specialist can perform certain tasks, and we don't produce enough of specialists. Have you heard of a body called CPS, College of Physicians and Surgeons in Maharashtra? I bet most of you haven't heard. This is the 105-year-old university which can give diploma in anesthesia, diploma in gynecology, diploma in pediatrics. It can convert the entire 50,000 doctors we graduate every year as specialists, who can help reducing the maternal mortality. But unfortunately, only Maharashtra government has recognized the course. And recently, Gujarat government. Karnataka state has the largest number of medical colleges in the country. And every 3 months, we get an advertisement stating that there is a vacancy of over 2,000 medical specialists in government hospitals. So if you want to have a better healthcare outcome, India doesn't require money. We require policy changes. We can't change any of those unless the government looks at medical education as a very integral part of the development. Interestingly, US has 19,000 undergraduate seats and 32,000 PG seats. And we have close to 50,000 undergraduate seats and only 14,000 PG seats. The other important thing what we have to do is to allow the nurses for upgrading skills and becoming specialists. There should be a career progression. Otherwise, nursing profession is going to die. Admission to nursing colleges in this country has come down by 50%. Half the nursing colleges in Karnataka state has closed down. In 3 years' time, doctors may have to wear skirts and treat the patient as nurses. It is going to happen. 67% of the anesthesia in US is given by nurse anesthetists. We don't allow a nurse who has worked in critical care for 20 years to prescribe a paracetamol tablet. We have to empower them. We have to look at alternative ways of funding healthcare. 10 years ago, we proved that with 5 rupees per month, you can run health insurance and you can do major heart operation. We have 850 million mobile phone subscribers who are spending 150 rupees per month just to speak on the mobile phone. If we can collect 20 rupees from each mobile phone subscriber, we'll be able to offer healthcare to virtually everyone. Taxpayers' money going forward cannot pay for the healthcare. People have to pay in some other ways. We have to reduce the cost of building hospitals. There are 100 towns in India with a population of 500,000 to 1 million where there is no heart hospital or a specialty hospital. So we built a low-cost super specialty hospital with 300 beds with CT scan, MRI, cath lab, cardiac surgical facility. We wanted to build it for $6 million, and we built it by spending $7 million. And we wanted to build this hospital in 6 months. We built it in 8.5 months. It is possible. Every large city like Delhi or Bombay or Bangalore must have at least 1 or 2 health cities with 3,000 to 5,000 beds where cutting edge work is done. In Bangalore, we have 3,000 beds. Our intention is to increase it to 5,000 beds and perform 60 heart operations in a day. We do about 30 to 35 heart operations in a day. And we want to attract 10,000 to 12,000 outpatients per day. And this is important for every large city. Going forward, it's very important that a country like India invest on software which will help delivering better healthcare. Today, all the standard hospital management softwares are hospital management software, not patient management software. So we are working with the very good software companies of India which will produce mobile apps so that when a patient gets admitted to the hospital, instead of a file, he will have an iPad. And the advantage is when our patient gets better treated in a cardiac ICU in Cayman Island at 12 o'clock at night, our nurses in Bangalore can take care of the patient. It is because it's 12 o'clock in the afternoon. This is where we will go. And the last thing I would like to request all the policymakers is that we have to use simulators to train our medical manpower. Universities give us the knowledge. It doesn't give us the skill, whereas driving schools gives us the skill. So we have to change our approach towards training medical manpower. Thank you.
Good afternoon. Good afternoon. Future of healthcare. I think this is an opportunity where we get to get out of our daily workspaces and think of stuff that other generations are going to do. And that's what I was going to say, except that Sunita has butted me on that and basically told me that pretty much some of it I'll have to do when some of the colleagues in this table will not be around. So I'm going to take advantage of that and talk about what's going to happen in my century. 21st century, in my belief, will change the sector radically from what we've seen in healthcare over the last couple of centuries. What has happened in other industries in terms of revolution, in terms of automation, in terms of technology, is bound to happen in healthcare, which has currently stayed away from it, vis-a-vis cost, vis-a-vis quality, and therefore I firmly believe in all that's happening in other sectors today. India is going to be affected by that, and healthcare specifically is going to be affected by that going forward. Therefore, what we do expect to see in the 21st century is high quality but low cost, which has kind of come hand in hand with cost and quality so far. I'm basically going to classify my comments in 2 buckets. One is what the world is going to do to healthcare, and second is what we as healthcare should do to the world. And therefore the first, which is what the world is going to do to healthcare. To my mind, going forward, ownership of taking charge of your health has to be down to your individual level, which is currently evaded us as citizens of the humanity. We need to be more and more accountable for what we are going to do to ourselves in healthcare rather than what healthcare is going to do to us. Ownership, taking charge of your own bodies, your own mind and soul, and therefore focus a lot more on preventive care rather than just landing up on sick care is going to be the mantra to my mind going forward. Technology has played a very vital role in healthcare in the last 30 to 40 years, whether it is diagnosis or it is treatment. I believe that what the 21st century is going to see in technology, and loosely speaking, IT. IT is going to make more changes in healthcare than healthcare is going to make changes in itself going forward. With new sorts of technologies, hopefully, and not probably hopefully, but certainly probably, as soon as you're born, a chip being inserted in your body and getting to know all your vital parameters, you're probably getting a call on your mobile 3 hours before getting a heart attack saying, get to the ER, you're going to have a heart attack, are going to become realities and probably make Devi's and Dr. Sreyan's life a lot simpler in catching hold of patients that are prospective MIs. And that technology is actually going to make you move. It's going to get you to get exercise, get you to get the right food, and take preventive healthcare steps so that you probably don't need sick care going forward. Access will get radically transformed with technology again, whether it's proximity by virtue of having some of these devices, whether it is having low-cost healthcare available like Devi talked about in 500,000 and 1 million towns, or just the speed of information going across so that you can actually take timely action. So whether it's telemedicine, whether it's the internet, or it's just technology, I think that's going to be a complete sea change going forward. The other thing that I think healthcare has avoided all this while is going to be the 360 of healthcare. Clearly, allopathic science has taken the predominant share of the market in healthcare, but I don't think we can actually avoid for too long the benefits that other health sciences bring to the table. And then a certain kind of union or unionization or integration of health is bound to happen because every science works on a particular part of your body and life. And therefore, I think a certain amount of integration is going to come through. And again, going back to preventive more than treatment. A healthcare ecosystem, to my mind, is something that will be required and demanded going forward. Today, you come to a hospital, you go to a primary center, you go to a diagnostic center, they don't talk to each other, there's no handover. Everybody makes you repeat everything because they're not comfortable with what's going on. I think that is going to certainly change. And lastly, what the world is going to do to you is make delivery much more personalized. It's going to be treatments for me, by me, and specifically tailor-made for me rather than the run-of-the-mill. So I think that's largely what the world is going to do to us in healthcare. What we will do, I'm going to make it quick and fast. I see the timer ticking away. I think we, as healthcare providers, need to put patients at the center of everything that we do. Today, the patients have to literally run around. It's good exercise, but it's a lot of running around before they actually get treatment. Quality today, which is so relative, must be taken for granted. It must become the core of every healthcare institution. Standardization of clinical pathways and clinical delivery. There are rock stars in healthcare, as Sunita said earlier. They need to be rock stars as patients and rock stars as organizations, not rock stars as individual deliverers. And that transformation will make the whole platform become better and faster. We don't capture any data. We don't leverage our data. What the WHO just talked about, all the information that is there, we don't have registries and information that is easily and accurately accessible. I think that needs to change. Our focus on outcomes. I think we focus on a lot of other things, but actually what the healthcare outcomes of our patients are. Medical education, I think Devi talked a lot about that, so I won't touch base on that. And the last two C's to my mind. One is collaborative medicine. Medicine is too siloed today, even within hospitals, even within departments and individual physicians and teams. Medicine needs to become much more collaborative because the body is not siloed. You can't fix my heart without worrying about my kidneys and so on. And therefore, we need to work amongst each other, to talk to each other, one amongst specialities within hospital, outside hospitals, but also the larger ecosystem. And lastly, communication. I think healthcare suffers significantly on the line of communication. The patients are clueless of what's going on once they get taken care of by healthcare organizations. And you need to take charge of your health. You need ownership back to the patient rather than the physician. And I think that trend change will put the ownership and accountability where it needs to belong. And probably have a lot more focus on me taking charge of my health rather than you worrying about it once I jam it up with whatever else I do in my life. Thank you.
Good afternoon, and thank you for this opportunity. So where do we start? When we talk about Health India, or universal coverage, which is the new buzz. We are at best today trying to fix a broken system with band-aids of one variety or the other. But much like anything else you do in any country, if you want to take care of the health of your people, you need to look at it in its entirety, not in its little pieces of who can do what. Taking a page out of the United States, you know there's no way you can, in the current technology and the way we practice medicine, that we will be able to provide healthcare, affordable healthcare to all our people. So starting with, this is now free season for election slugfest, Modi versus everybody else. That there is data coming out which you would never hear otherwise. 17% of villages in Bihar have electricity and 30% have toilets and 70% go into the jungle and all that stuff. So you know that you must face reality. The reality is not this room. The reality is the last man standing on the ground in any of the states. So we can show off, I can show off, anybody else can show off about what we have accomplished, but actually it doesn't amount to much. So one starting point is decrease disease burden. If we cannot even provide sanitation and clean drinking water and mosquito control to our people, your actual burden is doubled. So that is one part which only the government can take care of. So it clearly lies in their segment. Now coming to healthcare, that is basically disease management now. We should build our system ground up. That means the new blueprint Health India. We have over 800,000 ASHAs, ASHA is for Accredited Social Healthcare Activist. It's a long word, but does nothing. So we are paying 800 people out in every village, supposed to apply balm to the idea that there is a healthcare activist. They have no knowledge. If you look at the training programs that they go through, is virtually zero. So it's a huge burden on the exchequer, not accomplishing anything, but at the same time providing a huge opportunity for our frontline health worker. So all we need to do is to upscale their skills so that they can be your eyes and ears at the ground level. All they have to do is to find out, first monitor hygiene, second find out who needs help, a medical help. Second, we talk about doctor in every village. I mean, we should open our eyes and wake up from this utopian dream. There are not enough doctors. There are 500,000 doctors in this country registered today. There is no way a doctor will go to a place where there is not even a bathroom to go to and his children can't even go to school. So forget about that. So what do? Innovate. Like somebody said, there are district hospitals, civil hospitals, and I did a little study on Sonipat district. Population 26 lakhs, 351 villages, but has 4 government hospitals, 1 district and 3 civil, conveniently and very well planned, I should say, 60 kilometers from each other. So if you took mobile systems from each of these hospitals, which are located in B or C cities, where anyway the doctors can have all the facilities that they need, you could cover the entire villages on an every 2-day basis from each hospital having 8 mobile units. So it would take 64 doctors to cover the entire district, which otherwise you would say maybe 150, 200. So there are many, many little things. There are many experiments in Africa that have worked on this lines. But today what ails us is there is the private sector, there is the government, and there is the NGO. There are huge, thick firewalls between all of us. Unless we start thinking that no matter who owns a facility, who owns a clinic, who owns the human capital, it is all Indian. It's all India. It doesn't belong to me, him, or the government, or anybody else. Ultimately, it's for India. So we must break down these walls and then build our system of who will take care of the primary care, which government will. Secondary care, government with the help of private sector can definitely upgrade the existing facilities. We don't need to actually build new infrastructure because we can actually reactivate the existing structure. Tertiary care, well established around the world, government is not able to provide tertiary care to its entire population. So maybe the private sector can help over there and the government can become the purchaser of healthcare at the tertiary levels. Again, like Devi Shetty said, there are many schemes. Government has RSBIS, Bio have come up, many schemes. All these need to be integrated into a vertical system, and then we can hope in coming years, 5 to 10 years, that we will collectively build a system which has a hope of not only providing healthcare that we learn from what we have learned from modern medicine, but bringing into the fold traditional medicines which have huge potential, and India has the reservoir of wealth in that segment, which we are already doing. We have already had huge success in Parkinson's, in multiple sclerosis, in Alzheimer, and some of the other diseases. In incorporating Ayurveda into modern medicine, it's almost like a fusion. So there are many innovative models, but we must think health India rather than health private, health government, health NGO, or any of the fixing that we are trying to do today. We have to continue doing that, but at the same time, somebody, a group of people, a think tank or whatever, has to make this integrated, and we hope that we will see that utopia that we want to reach one day. Thank you.
Have the slide clicker. Well, good afternoon. It's a real honor and privilege to be here with this incredible, distinguished group. I was asked to speak a little bit about some of the things that are going on at Stanford and maybe more generically in the States. And I would say the challenges we're facing are at some level more similar than different. I think certainly the degrees of challenges may be different, but the challenges and the solutions are very different. If we could flip to the next slide. So we have a big challenge at Stanford. Does anybody have this slide clicker? I could flip more quickly. No? AV people? Yes? Oh, thank you. Perfect. Great. I'll just flip through these quickly. When you work in healthcare management, you can't help but do PowerPoints, so I'll be very fast. So we have this big vision of healing humanity, we say, through science and compassion, one patient at a time. Really the same vision that we've heard here. And I think when we talk about tertiary care and advanced care, we presume the quality is good. I hate to break it to you, the quality is very mixed. It's very variable, even at organizations such as ours at Stanford. And for example, these are what are called survival curves. You see here kind of survival rate years out from diagnosis with very advanced cancers. So 2 years out survival, I'm happy to say at Stanford, our survival rate is 75% versus 49%. So I'd say one point is don't assume the care is the same everywhere. The variability is great. And we've heard a lot from Dr. Shetty and others about how you can standardize this care using protocols. Huge opportunities there. The other thing that's been taken for granted in healthcare, let's see, is the patient experience. Certainly in big, prestigious academic institutions such as ours, historically, we said, you know what, patients, we'll let you know when you're satisfied. But that's not the consumer model. So now we're in the 92nd percentile, actually now the 95th of all hospitals in the United States on what the patient says. Ask the patient. So again, as people are becoming more consumer-oriented, how do we serve the patient makes a difference. And then we've pulled this all together, we say, into a strategy of how do we do leading edge, how do we do the best in treatments, have the best cancer or cardiac outcomes, but how do we deliver it in a coordinated way? How do we own the complexity of care? Leveraging techniques like we heard here, mobile, we call it lifelong health or population health. How do we stay ahead of what's going on in care? And we've started doing a lot of design work. We've talked to patients, and they've told us a few things. And we followed patients not only in the hospital, but to home, to work, and talk to their family. And they said a few things to us. They said, know me, show me the way to navigate through the system, coordinate the complexity for me, and apply the leading edge. Give me the best treatment. And so we did some design sessions. We worked with a design firm, and we started with this concept of know me. So anticipate my needs, know me who I am as an individual, my religious, ethnic, social background, know me from a genomic perspective. Show me the way. Huge opportunity in mobile, both really around the world. How do we coordinate, be predictive? And sometimes it's as simple as where do I go? But sometimes it's more give me an explanation to what's happening. Coordinate for me. Coordinate the complexity. So we now have a team of telephonic advisors, and we heard from other great organizations that are doing this, like Medicall in Mexico, where we serve huge companies, Apple, eBay, Intel. Any of their employees anywhere around the world can call us, and we help answer their questions. It's not always medical. It's giving advice. What should I do next? How do I access this information? And finally, apply the leading edge. How do we apply this technology and apply it ubiquitously? So we've launched video visits. We do tele-primary care, urgent care, dermatology, psychiatry, tele-orthopedics for low back pain. And how do we take this technology and take it outside, take our competencies, take them outside our buildings and deploy them? And it's really the same challenges, whether it's with those of a higher income level or those with less access. We all have access problems. Actually, our specialty demand in our medical centers is completely full. And a lot of the care that we're doing doesn't need to be in the medical center. So we have a goal for ourselves to take away 20% of our visits, eliminate them, and we say, put it in the cloud. And so this challenge of how do we do this leading edge and coordinated care and apply these approaches like lean thinking, patient-oriented approaches, and design thinking to healthcare. Thank you.
I think the collective knowledge that I have on this panel calls for more than 1 hour, but since we had to limit their time, I'm going to just ask them 2 questions, and let's hear their views. Let's fast forward to the year 2030, because we're talking about future perfect. India will have not only the world's youngest population, but the world's elderly population, according to Hans Rosling, who's a very famous Swedish economist. As the clock turns, aging and diseases associated with aging will be our next challenge. What, in your opinion, are the biggest challenges to healthcare? How do we innovate and create and nurture health systems for the future? Like a miracle drink, give me in 2 minutes, my fellow panelists, your prescription for the demographics of 2030. Can I start with you, Dr. Nana?
Yes, non-communicable diseases will grow. They are growing also because people live longer. What we have today as a big challenge is premature mortality from those diseases. So many people die before 60 because of undiagnosed non-communicable diseases. Globally, we know that half of the non-communicable diseases are not diagnosed. Those that are diagnosed, half is not treated, and those that are treated, only half bring us to effective treatment outcomes. So I think there is a big challenge which India is facing. We need to promote the comprehensive care. We can't treat all these patients, we have to accept that. So we need to very much focus on dealing with the risk factors, which are a very important determinant of those diseases. That has to do with lifestyle, that has to do with education, that has to do with bad habits, which have to be, again, fought against. So that it requires a lot of preventive approaches, which very much can be achieved through various technologies through which people can be reached and educated about those threats. Beyond that, of course, treatment and care is essential, but the chronic conditions do require a different care, different monitoring. Again, technologies can help here, but what is important that there is an uninterrupted monitoring of those conditions and that every patient is being followed. So we need to look at the rehabilitation, we need to look at palliative care, we need to look at the care which can be provided outside of hospital, and that can be done only if we have a sufficient providers of this kind of services, that we know where these people are, and that we have an information system which supports flow of this information. India will also have a great advantage because of access to medicines which are required for treating those diseases. Many of those medicines are affordable, of good quality, and they are not expensive, and a lot of them are having a great preventive value. If we achieve that, we can reduce significantly burden of those diseases. But we need to be serious about it, and we need to have a comprehensive range of approaches, both preventive, promotive, and rehabilitation, and other approaches.
Future hospitals will be dramatically different. The first change, what will happen is that whatever is done in the ward of the hospital will be done at home. Patient won't visit the hospital. So when you talk about a 100-bed hospital of the future, 90 beds will be critical care beds. That means we have to train almost all our nurses to manage a patient on the ventilator. There will be a dramatic shift. Then we have to look at the enormous cost involved in keeping someone alive at the age of 100, 105. It's not going to be very, it is going to be a very expensive affair. And we, as Indians, have a phenomenal advantage if we can build about 500 new medical colleges. Because as every country progresses, prospers, medical profession becomes less attractive. Medical profession is an attractive profession for children coming from deprived background because they can work for 18, 20 hours a day. So if we can educate as many doctors, nurses as possible in our country, we can take care of the whole world. That is an opportunity for us. So this is one area where we have to invest, and we also have to invest on technology. India is in a phenomenal position to develop software which will smoothen the entire process of delivering healthcare. So that's it. And also, other exciting thing what we will see, we may not have to wait for 2030, within the next 5 to 10 years, virtually half the people of this world, when they go to their grave or go to the crematorium, they will still have a heart which is working because that will be artificial heart. You may have to turn it off before you burn or bury them. Thank you.
Seems like our population is going to get larger. Shivender, what are your views?
So I'll make it short in bullet points. I think I'll put probably in the same buckets, one to the recipient and one to the deliverer. I think clearly preventive healthcare and taking ownership of your own health is certainly going to be one mega change and a solution that will help us solve this problem. And secondly, just a spin-off from Devi's point, is organ donation. I think a lot of laws and a lot of individual beliefs around organ donation, if treated, can actually save the world with almost every single disease that we have. So that's the two on the recipient's front. On the deliverer's front, I would say standardization of clinical pathways. We have 60 hospitals in our company. There must be somebody doing better cardiac surgery than everybody else, somebody doing better colon cancer treatment than everybody else. Can we not standardize that? And we can take it larger across our organizations into all our organizations. I think we've got a lot more solutions that we can possibly get from the rest of the world. And second is throw out our data and clinical outcomes so that the population knows why they're coming, where they're coming, and what they're coming for.
So all of the above, what everybody said. But truly, my vision is that there are two possibilities here. One, we will innovate enough to create the new era medicine which will emerge out of India. Because only we have that wealth of having acquired huge amounts of talent and knowledge from the West. And we are the only country which has a huge wealth of traditional herbal medicine, which if you just look under the covers, there's such a huge amount of work going on which we do not recognize, and maybe we are even afraid of it. So if we fuse the two, I think we will come up with that medicine which will not only be able to help India, but 4 billion people around us who will not be able to ever access healthcare which the West has perpetrated on us. And if we go further, I think maybe the United States and Europe can take a leaf out of that because they themselves are drowning under the same burden. So I think that is possible. I think we just need to take it seriously. And in addition, we can talk about upgrading skills, upgrading doctor knowledge and all this. This stuff will go on, that, you know, connectivity, IT, telemedicine. This is going to keep churning. This is fantastic. But the ultimate goal should be what I just said, the new era medicine which will emerge out of India. Thank you.
Double mic'd here. We're looking at healthcare transformation in 4 strategic areas. So we talk about complex care. So the innovation that's needed for neuroscience and cancer and trauma. How do you get the best outcomes? How do you get multidisciplinary? How do you know when to do something through a catheter, through open surgery, through radiation? What's the variability in the diagnosis? That's all over the map, all over the world. And the diagnostic capabilities are very different, even within one institution, between multiple physicians. So there's a set of innovations in what we like to call complex care. A secondary area we talk is our network of care. As we heard, a lot of care that was inpatient will move to outpatient, a lot that was outpatient will move to the home, a lot that was reactive will hopefully move to predictive. So how do we move care to an outpatient and regional distribution is a second area. A third area, if we have complex care and a network of care, our third area of innovation we call population care. A lot of folks working on population care, and we heard about it on the panel today. So we have a health plan now, and we are at risk for patients' outcomes. And so people talk about screening for mammogram and colonoscopy, and those things are good, but we often find we screen too many people for the wrong reasons. So really now we're combining population care and precision medicine. Who needs to be screened? And what we're finding with a lot of these concepts, we talk about the medical home, how do people have a home for care, is spending a lot of money on everybody to have complex coordination probably doesn't make sense. So there is 1% of the population that drives about 30% of the spend in our country, about 5% is driving 50%. These are patients with multiple chronic conditions and complexities. How do we focus our resources in our country on those patients in terms of reducing spend and increasing access? So complex network, population care, and the final area for innovation we heard a lot here is ritual care, which I think spans across all of these arenas. How do we take things from a physical environment, move it out of a costly hospital or even clinic, and put it into the cloud? So those are the 4 areas we're focused on.
They say that if you give a man a fish, you feed him for a day, but if you teach him to fish, you give him a lifetime. What we need today are clearly sustainable healthcare situations and not those which are entirely subsidized. In a very human context, we need to understand that things that are free lose value over a period of time. As the doctors on my panel know, there are 100 things that we need to do to keep the patient safe during surgery. I'm sure you're all familiar with Gawande's checklist, but all this comes at a cost. And so today, let me ask the panel to describe the perfect health system where cost, prices, and clinical outcomes are linear equations.
That's a complicated question, and there are several answers to that. But I think there is a huge issue of efficiency savings. I think we are always looking what is the new approach and new technology. I mean, there are a lot of things where if you don't change anything, but just do things in a better way, in a more efficient manner, you can already reach that. You are talking about sustainability. How can the healthcare system be sustainable when you are not pulling your resources together? You are fragmenting them, and each scheme then has its own transaction costs, etc. You are not reducing risks. I'm hearing, for example, that RSBY talks about expanding their territory from the secondary care into the primary health care, for example. Why to do that? Why not to reduce those boundaries, pool all those resources, in fact, both public and private, and look at how do you increase the pool for risk management. And I think this can make much more sustainable Indian healthcare system, and it can reach out to many more people than it does reach today. Of course, there will be always scope for private health insurance coverage, but at this point in time, only 13% of Indian population has decent coverage with the range of essential and required services that they may need. Only 13%. Now, if we continue to pulling it into vertical schemes where you don't have an information flow between those schemes, so the same patient can actually benefit from one scheme and another scheme and a third scheme, and the other patient can benefit from nothing, you won't get there. So I personally think there is a lot of reorganizational issues. There are a lot of technological issues which can help in that, but you need a goodwill for that. You have to stop looking at what is public sector schemes doing and investing in more infrastructure, more people, more resources, more buildings, etc. You have to look at what is the results that they deliver. And at this point in time, in India, you have only 30% of people diagnosed with hypertension. Only half of those people get antihypertensive medication, and only half of those get hypertension under control. So, okay, let's build more schemes and more hospitals and more treatment capacities. We won't solve the problem. Thank you.
I didn't understand your question, Preeta. Yeah, please. Yeah.
This is a good way of making me state a position here, but I think a simple answer is always good for a complicated question. The question is really about how do we pay for healthcare? It's as simple as that, and especially having doctors on the panel, you are extremely particular about clinical outcomes. And this is the challenge that CFOs also face, because doctors are, they wouldn't put in a cheap substitute when doctors have spent so much time preparing a patient for surgery. So you have, on the one hand, you have cost. On the other hand, you have a price at which you need to price the procedure, the product. And in the end, it should benefit all stakeholders. So this is the equation, and I'd like you to explain it.
Charity is not scalable. If you're going to do anything free, there is a limit to which you can do. Good business principles are scalable. Everyone in US and Europe want to talk about reducing the price. But if you ask them how much money they're spending, they don't know. Everybody wants to reduce the cost of heart operation, but very few people know how much it costs to do a heart operation. So essentially, whatever other industries have done to control the cost, we have to do it. We look at the mobile phone industry. Mobile phone industry is not a charitable company. They are making money, and we are able to, even beggars on the street are able to use mobile phone. So we have to learn a lot of lessons from other industries. Today we are able to survive because we have virtually no competition and people have no choice. A time will come when more hospitals will come up, then the real competition will come. Then we realize how to reduce cost and how to control. If a solution is not affordable, it is not a solution. We have to try and reduce cost. At the same time, we cannot compromise on the quality, because people have shown that just because some hospitals are offering services free, that doesn't mean people want to go and die in that hospital. So essentially, it's a complex question, but our industry is refusing to change with the principles of business, and we have to change.
So Shivender, what is your value proposition, Shivender?
It's to outlive most of the panel.
Well, we wish you luck.
I heard two questions, Sunita. One is what's the perfect health system, and the second is what's the way to have cost and outcomes and keep a happy place between the providers and all the stakeholders. So on the light note, perfect health system is the Apollo health system. So,
Thank you. Did you get an MBA?
marriage and bhog attendance? Is
No. Masters in business.
I think honestly, the perfect economic equation to my mind is actually trying to stay out of the hospital and stay healthy and prevention therefore. Prevention is expensive actually. It's not a cheap solution. It's a daily cost and so on and so forth. But I think that investment actually gives you a much better outcome. If you just look back a couple of generations and people who've actually lived 100 years in India didn't have any of the healthcare access that we have today. But they did the right stuff, and I think really honestly we have to move towards keeping people out of the hospital, not by virtue of treatment, but by keeping them healthy. And I think that's the best economic model at the end of the day.
Dr. Naresh Trehan, I saw you working with Anna Hazare. So I'm sure that, and I also have seen your beautiful hospital in Delhi. So I'm sure you'd give us your insight, which would be most interesting and valuable.
So it means you need to wear many, many hats. You know, if you really want to talk about reducing cost and making efficiency, I mean, all these things go hand in hand. But if you start with where is India suffering from to begin with, is that if you break down the cost of creating a facility, 30% of the cost is medical equipment. And that by itself zero is produced in India. It's beginning to be produced a little bit here and there. And you see the humongous cost of adding to the patient. So if you're saying that you're going to have equipment which is actually going to diagnose properly, you could have cheap stuff and then miss a lot of things also. But it behooves you to get the best, because when the patient comes to you, you must deliver the best to them. So if you're saying that your cost of acquisition of technology is so huge, you cannot actually ultimately deliver to your people what you want to deliver. The second thing is the doctors have gotten used to the good life. Huge cost, human capital, huge cost. And that's what actually is breaking the back of the system today, because there is escalation which you cannot imagine. It's just the
imagination is limited by their quantum thinking. So, well, at least I earn my living here. And that's why I don't want to say much, because I'm in a rush. I got to do my second half, earn my dinner tonight. So, no, but I think you know it's too huge. I'll give you an example in heart surgery, and I'm sure it's been done by everybody else. Is like we converted from on-pump surgery to off-pump surgery. Straight away saved 30,000 rupees for the cost of an operation, and we actually took it away from the patient's cost. So for last 5 years, we have not raised the cost of doing heart surgery because of the fact that we could live with that 30,000 extra, and we passed it on. So there are many, many other things we can do, but it's too short a time, and I think we should give others opportunity also.
Mr. Rubin, who's flown in from Stanford, in the US you have a Mayo-type college, a Mayo-type institution, which I've heard has the capacity not only to earn billions of dollars, but raise billions of dollars through donations, and therefore they provide really very good quality healthcare. You also have enterprises like HCA, which charge patients. So where do you see, what do you see as the ideal healthcare system which is sustainable and where the value proposition is still strong?
Yeah, so obviously a complicated question, as everybody said here. I think there's two aspects to the question. One is a question of financing. So how is health coverage, as we heard, how is that financed? And I think the way one finances it is going to be impacted by the history of a nation, of its political environment, of its economic model. And I think the fact that we don't see one perfect model tells us something. So if one is here today, it might be impossible to be here tomorrow, wherever that is. So there's a financing question, and in our country, in the US, the financing is a combination of employers. 85% of individuals who are employed get their insurance covered, financed in part through employers. 15% were uninsured, and we had an Affordable Care Act that tried to deal with that, and that's a whole other session. And then for the very poor and those who are aged, there's coverage through government program. So financing and then delivery system. In our nation, delivery system by and large is private, whether it's private, nonprofit, and academic like a Stanford or a Duke, whether it's private and for-profit like an HCA, or whether there are other community hospitals. And there's differences in those, but in general, I would say those are all institutions that do an excellent job in their own way. And why should we think, finally, if there's financing delivery, that there's one answer for every person? You can choose your cell phone, so everybody has to have the same health care. And why would we think somebody with cancer needs the same things as somebody with diabetes, or somebody who's 85 would need the same solution as somebody who's 40? So I think what we're seeing in our nation is different models of care, different experiments of care, and where things are more privately financed, what we're seeing is a change in the reimbursement systems. I think our system works perfectly. It works perfectly to deliver the results that the reimbursement defines. And we were paid to do everything, so the more you did, the more you got paid. It wasn't because the doctors were bad or the hospital administrators were bad, that was the system. And so we're evolving that system in different ways. We have population reimbursements, we might have episode reimbursements, but again, it may be very efficient to pay for heart surgery if people need heart surgery at a fixed rate. So I think financing and delivery system and multiple models are the approaches we're looking at.
Dr. Devi Shetty wants to have the last word. What do you think? But I'm going to conclude after he does.
If you really want to reduce the cost of healthcare in India, government should not look at healthcare industry as a money spinning industry for them. First of all, when we bill a patient 100 rupees, believe me, minimum 30 rupees goes to the government in the form of some taxes or other. I'll give you one example. Industries across the country pay 5 rupees per unit of electricity consumed. Hospitals pay 7 rupees per unit of electricity consumed. Why? Because government has categorized healthcare industry with the entertainment industry, wherein shopping malls and movie theaters pay 7 rupees and we are in that industry. It costs 500 rupees per day to park a patient just in the general ward for electricity tariff. 500 rupees per day. So unless the government looks at this industry, which is as important as any other industry, we don't want special status. But don't treat us like entertainment industry.
Well, I'm sure they can't help it, Dr. Devi Shetty. I mean, my panelists are so good looking that they always need screen time. So let's conclude this really nice session. I think, you know, for my 30 years of working with Apollo, I am much older than Shivender. We are fortunate to have had the wisdom from the past, the collective knowledge which is current, and the energy and the insight to change the future. This session is called Future Perfect, but the answer has not been so simple. It could have been straightforward. I mean, there were so many good ideas on M-Health, on preventive health care, on Ayurveda, on learning from Stanford's health systems. They are, I think for the past 36 hours, we have heard insights from intuitive coalition partners and panelists. But I look around me and I see how far we've come. I don't need to be a Nostradamus or an astrologer to say that the future of India, indeed, the future of our country, is codependent on the health of its citizens. And that is the role that we play. Interestingly, it is become the most important agenda for any president, for any prime minister, and for every country. In the Mahabharata, Krishna takes Arjuna in the middle of the war down the battlefield. And there Arjuna experiences, you know, his family on one side and his brothers on the other. He sees Bhishma on one side and his brothers on the other. And he has a very difficult decision to make. And I think it's clearly, you know, we do have a challenge in front of us. We don't have a Kurukshetra. We're not battling. We're working together as coalition partners. But to do that, I think we need the courage to work together. But above all else, I think we need to have the humility to learn from the experiences and the knowledge of others. Ladies and gentlemen, I hope you found this session interesting. I truly have, because I believe that the future is happening right now and that all of us are part of that future. Thank you again for joining us on this session.